Hello, welcome back. I'm Dr. Mark, and we previously talked on a previous short about the new approval by the FDA about narcan, about naloxone. So this drug that is of course used as a reversal of an opioid intoxication is now all over the counter, so you can buy it in a pharmacy without a doctor's prescription. So today we're going to get a little bit deeper in naloxone or narcan, and we're going to talk about how this drug is used. Of course, many other countries in the world already offer free even or at least over-the-counter versions of naloxone. So I am going to talk about it as naloxone, not narcan. Narcan is the name of the brand in the United States. There are a few others, but narcan is the most known. But other countries have different names, thus we are going to call it naloxone. So naloxone is of course a very important drug. The way it functions is when we consume an opioid, like for example morphine, it reaches our body, it reaches our nerve cells, mainly our nerve cells, and it will bind to two main receptors. They are called mu receptors and kappa receptors. There are others like sigma, but we are going to focus on this video on mu and kappa. And thus, when we have that morphine stick to our mu and kappa receptors, we get all of the effects that opioids generate. So we get the analgesia, we get this diminishing of pain that is very important and one of the main reasons we use opioids. We may also get sedation. We are also able to make an anesthetic induction, so the patient gets anesthetized to go into a medical procedure, among the other things. We may also see from this coupling of morphine, for example, to these mu and kappa receptors, that we get nausea, we may get constipation and we can't go to the bathroom, and we may get, with very high doses, of course, respiratory depression, coma, confusion, sedation. Now, opioids are an extremely powerful drug, and this is why we use them. They can have very, very deep effects on our bodies, and some of the opioids, they don't have something called a ceiling, an effect ceiling. So the more dose we receive, the higher the dose, the higher the effect. In a patient with very severe pain, this is of course a blessing, because the more pain the patient has, the more opioids we can give him or her, and the more we can control the pain that patient is feeling. So once again, very good news. They also have a couple of very important considerations. Number one, there is a toxic dose, so when we give a very high dose of opioids, this can lead to a very severe depression of our brain, of our nervous system, and of course the most severe complication, we can have respiratory depression, hypotension, and of course we can die from a toxicity or an intoxication with opioids. The second aspect is that they are highly addictive. In a patient that uses opioids for a long time, the risk of becoming addicted becomes higher and higher. This means that, as with many addictions, we may get tolerance and we may need to increase doses of opioids to get the same effect we previously had. Of course, this leads some patients to ask for higher doses. They may not get them from their physician, and this also opens the door for black market. So if I can't get the opioid I need to feel fine with my doctor, I will get it from somewhere else. And they might reach a point where they have toxicity. Once again, the most severe of the toxicities, the respiratory depression, but they might also find other adverse events. Of course, respiratory depression and opioid toxicity can kill you, so a couple of minutes after you ingest or you administer this high dose of opioids, the patient can be dead. And thus, a drug that reverts the effects of opioids is also extremely important, and that is precisely naloxone. Naloxone is what we know as an opioid antagonist, so it basically, when we have the mu and kappa receptors, naloxone gets in the way of morphine, for example, trying to bind to that receptor. It prevents it from binding, and even if morphine was already in the receptor, it can displace it, and it basically prevents it from activating the receptors. This means that a patient that was basically on the floor, unconscious, and on the brink of death, we can reanimate that patient. We can bring him or her back to consciousness, and we can diminish or disappear all of the effects the opioids have. Naloxone also has a rapid onset of action, so when we administer it in about 2 minutes, we should find the complete effect, or at least starting the effect of the blockage of opioids. Another great advantage is, of course, that a patient that hasn't consumed any opioids doesn't has any effect on that patient. So naloxone is very safe in a patient that is healthy, let's say it that way, or not healthy, but a patient that has not consumed any opioids. That of course is very good news to first responders, security teams, police departments, and all those type of people that find people unconscious on the floor and they need to decide what to do. So what they do is, when they suspect a patient might have consumed opioids, they grab the naloxone, they apply it. The easiest way to apply it, and the one that got just approved by FDA, it's a nasal spray. So you take the nasal spray, you put it in the patient's nose, and you give one spray. Usually the patient recovers. In the first 2 minutes you should see a significant effect. If the patient is unconscious because of another thing, it won't affect his or her health. And of course, after this first spray, you need to call the emergency services to take that patient to the hospital. We're going to explain in a bit why you always need to call for emergency services. If the patient doesn't respond in these first 2 minutes, then you apply the second nasal spray, and the patient should have a good response to naloxone. There are other presentations. So in other countries we have intramuscular, intravenous administrations of naloxone, and even subcutaneous administrations. Those are all very good. They act very fast, and we can use them. Of course, it's more complicated because we need a syringe and we need to know how to apply an intramuscular, intravenous, or subcutaneous drug, but it can be done. And once again, it's important to underline that every patient that we suspect had an overdose of opioids should receive as fast as possible naloxone. With that being said, there are some complications that can appear in response to naloxone administration. Number one, we can find that naloxone doesn't last as long as most opioids. So the effect that we get from naloxone is from 30 to 90 minutes. That's a very good time to reach a hospital, but once the naloxone disappears from the body, once we lose that effect, we might find the patient once again with an opioid intoxication. So very important to call emergency services and take that patient to a hospital as soon as possible for more advanced management. Number two, since naloxone is blocking all of the opioids from all of the receptors in our body, mainly mu-kappa and some others, we might find that a patient that has taken opioids for a long time might present with abstinence, an abstinence syndrome. And this means that the body and the brain got so accustomed to being surrounded by opioids that brain doesn't function well anymore. So we will find the opposite effect of opioids in the patient very, very fast. If a patient that usually consumes opioids might be like very relaxed, kind of sleepy, with stomach problems like constipation, it can go to the bathroom. For example, also the patient might have hypotension, the patient might be a little colder than a patient that doesn't have any opioids, and the patient is pain-free, or at least pain decreases in a significant amount. A patient that is undergoing an abstinence syndrome is just the opposite. So we have a very anxious patient. The patient might even have a seizure, might have hyperthermia, might have hypertension. So just the opposite, might have very severe pain. This might be nerve-wracking to experience that with the patient, that abstinence syndrome that also appears really, really fast because of the naloxone effect. However, it's important to say that the abstinence syndrome will less likely kill the patient versus the opioid intoxication. So we have to administer the antagonist, naloxone. The patient might experience this abstinence syndrome. This is the other reason why it's very important to reach the hospital as fast as possible to give a proper management to the abstinence syndrome in case it continues. But it is definitely possible and even frequent that patients that have chronically taken opioids and that we administer naloxone to experience an abstinence syndrome. Finally, because of these potent effects of naloxone blocking the effect of most opioid drugs, or of all of opioid drugs, the recommendation is that any patient with a chronic opioid consumption because of a medical need or any other reason should have ready naloxone. The easiest way to administer, once again, it's through nasal spray, but if you don't have access to nasal sprays, then at least an injection with naloxone ready to be applied. And of course, the patient won't apply it. So we need to tell family members, caretakers, or a neighbor, whomever may find us lying down in the ground, where is our naloxone, how should they apply it, if it's intramuscular, how is that technique for intramuscular application, etc., etc. So, as other videos, I will leave some references in the box below, in the video description, so you can read more about this approval and the use of naloxone. And of course, be very, very careful with this drug. They are a very good group of drugs. However, misuse, and even if with a correct use, the chronic use of opioids is a high risk for most patients. So with all this, I hope this video helps you to understand a lot more about opioid use, and specifically about the reversal of opioid intoxication with naloxone, a commercial name in the United States, narcan. This is it for today. Thank you very much for watching this video. As always, I was Dr. Mark, and help us change the world, share the information.